morning, everyone. Thank you for joining us at 8 a.m. in the far, far world of the McCormick Place. This is our second Diabetes Care Journal Symposium entitled Let's Pick Up the Pace, Addressing Inequities in Diabetes Care. So happy to be having this very important discussion this morning and certainly getting some input from our experts. Our first speaker this morning will be Dr. Athena Phyllis Samikas from Scripps Scripps Institute, Diabetes Institute. Come on up, Athena.
Good morning, everybody. Happy to be here and to be able to present on this topic, non-medical factors that influence diabetes-related complications. Let's see if we can get this going. These are my disclosures. I thought I'd just start by telling you where I'm from. I'm an adult endocrinologist, and I'm at Scripps Health, which is a community health system in San Diego, California. We have 5 hospitals there, but we have 2 hospitals that are right on the Mexican-American border. And within those hospitals, about 40% of the patients have diabetes on the 2 that are right on the border, and 70% of those patients speak Spanish. You can see the racial and ethnic mix there. And then I'm part of the Diabetes Institute, which is the service line that creates all the order sets across the entire health system. So I get an overview on complications and things that folks are coming in for on a very regular basis and how we can institute proposals and ways to really try and improve this, not just for our health system, but really for our entire community, which I've done work in for a very long time. I thought I'd just start. I know you've probably been to a lot of sessions that show these prevalence rates, but this just came out a few months ago. Venkat Narayan, who was honored here as one of the distinguished awards from the ADA, showed that there's really over 800 million people with diabetes in 2022, and 450 million of those are untreated, many in low and middle income countries, and are affected with the complications of diabetes. Interestingly, the rates in both type 1 and type 2 diabetes are increasing. I'm one of those folks that still gets a newspaper delivered to my door. And the Wall Street Journal had this just the other day in it. And of course, not surprisingly, chronic disease remains one of the biggest health risks in the U.S. And the diseases at the top are hypertension, obesity, diabetes, and chronic kidney disease. The article noted, again, not surprisingly for us, but lower life expectancy than most other countries. Most of the gap in the working age adults. Fractured health system is contributing to this. And although the U.S. is very good at treating complex disease, it's really worse at providing access to care and services that help to manage or prevent illness. Some of these reasons that contribute to the non-medical causes of complications. So what are these complications? Just briefly, there's the traditional complications, the micro and macro vascular diseases of diabetes, but there's a whole emerging group of complications as well that you can see here, cancer, other disorders that are showing up. And I was recently part of a Copenhagen declaration that included many people from the North and the South hemispheres, where we again looked at what's causing all these complications. And some of it are things that we don't traditionally think about as the causes of the complications of diabetes. Many of those sessions were led by another 2 people that were honored here this year, Melanie Davies and Juliana Chan. So from one of the symposia last year, and one of the publications in diabetes care last year, what are the trends in the diabetes complications that are occurring? And, you know, for the first decade of 2000, we were doing good. You see these declines for the most part in the complications of diabetes. But on the right-hand side, you see what the inequality trends are within those complications, because in the last 10 to 15 years, the trends have actually started going up again. So when you look at hypoglycemic crisis, the disparities exist in age and race and ethnicity. That never really went down. That continues to go up. But when you look at something like heart failure, the race and ethnicity disparity continues. Heart failure, stroke, myocardial infarction. When you look at the age disparity, it says it's gone down, but that's a little bit deceiving because it hasn't gone down because we're doing better with older people, but because younger people are actually getting these complications at a higher rate. So we're not doing better there, we're actually doing worse. And the same then holds true for end-stage renal disease, where there you see a decline in race and ethnicity disparity. But that's really because there are more non-Hispanic whites that are getting this condition. And really, overall, we're not doing a good job. There's no decline in other race and ethnicity groups. So once again, we're not doing better in this disease state. So I thought, where should I turn to ask what is the cause of the complications? And of course, just like everyone else today, I turned to Google and AI. And I asked it, what are the main reasons for complications in diabetes? And it said high blood sugar levels over time, high blood pressure, all the traditional things, cholesterol, smoking that we know about. It threw in genetics, obesity, lack of physical activity, poor diet. It gave me a little figure there from one of the societies that associates it. And it had this concluding statement: by managing these risk factors through lifestyle change, medication, and regular checkups, you can significantly reduce developing long-term complications. And I thought, well, it's missed the boat a little bit here, right? Because we are doing a lot of these things, and yet I just showed you a chart that showed we're not doing better. So what do we have? There are a lot of guidelines, and the ADA does a pretty amazing job every year in the standards of care of putting forth guidelines that help tell us what are the best ways that we should be doing for everybody to guide treatment. There's this lovely temple. You can probably tell from my name I'm Greek in background, so I like that they put this in a Greek temple. And I'll come back to these. You can see what they're recommending, once again, very similar to what Google told me. Glycemic management, blood pressure management, lipid management, and cardiovascular and kidney benefit. So I asked the question again. I thought maybe if I asked it a little more specifically, why do the disparities exist when we have such wonderful meds and technology to take care of diabetes? So it gave me a little bit closer answer now to what some of these non-medical reasons are, and included social, economic, environmental factors alongside biological and behavioral influences, and that these disparities disproportionately affect racial and ethnic minority groups, leading to the increased complications. And you can see the areas that it has touched upon here. Socioeconomic disparities, rural-urban disparities, racial and ethnic disparities. And we've had these two types of figures for a long time, I think, that tell us when I, as a physician, go out and try and deliver care for my patients to improve their care, that bottom part here, the 20%, is about all I can affect with my medical intervention. I can maybe affect a little bit of this health behaviors with the education that I provide, but there's a whole lot of other things up above that need to be influenced and are a lot harder to be influenced. And you'll be hearing from both Daryl and Matthew on some of the things that can be done as interventions. On the right side symbol there, figure, you see community, and then even bigger at the system level. And we heard yesterday from one of the congresswomen at the other diabetes care symposium, if anyone was there, Dr. Kim Schreier was amazing in what she spoke about. I was so impressed. She's in Congress trying to implement some of these changes that, again, can improve non-medical reasons for development of diabetes complications. So back to Google and maybe even a little bit of ChatGPT here, digging down even deeper. What are the reasons? Why do these disparities exist? And it did a pretty good job in getting a little bit deeper in this. Health system bias that exists, and you'll hear a little bit about this from Daryl, a little more detail. You know, many times we don't even know this exists. We've got these fabulous guidelines. If anybody was at the talk that Monica Peak and Dan Rubin did a few nights ago, or maybe it was yesterday, they talked about this, and we want all the best offerings to be offered to everyone equally. But if you have some of these social determinants or drivers of health that are intervening, we really do need to think about how to address those as well. Health literacy, addressing some of the cultural competency in the way we deliver some of our interventions and education. And the digital divide, although it's gotten better for sure, it still exists, and having to overcome that in order to help patients do better with their care. So even if we overcome this, I said access was a big barrier. If we give everyone access, and we did, right? Several years ago, we did provide greater access to many more people. Does that improve care and lead to equal outcomes? And once again, when I asked for an AI response, it actually gave me a pretty good response. If everyone has health plan coverage, are there any differences in who develops the complications? And the answer once again was yes. Even when everyone has health plan coverage, differences exist in who develops diabetes complications. There have been a number of studies written. I just put a few examples here. Technology in particular is an area that's affected, and the one on the right, Matthew was part of this group, as well as Amisha Walia here in Chicago. There's others that have demonstrated that technology in particular, there's a disparity there. And again, a beautiful recommendation from the ADA on how we should care for people with type 1 diabetes, with stars on what are the best approaches. The stars are for the automated insulin delivery, where you have CGM plus pump. Other recommendations then follow. There were studies that were done back in the mid-2000s that looked at if you gave people only injections, what was their average A1C. This was from the Type 1 Diabetes Exchange, on the highish side there, around 9. When you give them technology as a pump, it drops a little bit. When you add CGM, whether it's injection or pump, you do dramatically better. So we would want to be giving this to everybody, right? But unfortunately, in some follow-up studies, what we see is that once again, there are disparities here. They were racial and ethnic disparities, but they exist along other areas too, falling mostly along the socioeconomic area. And one of our research scientists in San Diego, where I work, Dr. Emily San Diego, looked at this in some of the community health centers as well. And what she did is she looked at the primary care group of people taking care of diabetes, and that community health center, interestingly, had added an endocrinologist recently. And she looked at what was the difference between the endocrinologist delivering some of the technology as well as the primary care, and found that if you're referred to an endocrinologist that understands the technology well, actually has passion about getting it to the patients, and also knows all the tricks on how to order it, that those folks actually got their technology much more frequently. So there's a lot of things that exist in order to try and get people what they need to deliver that best care that aren't necessarily always medications and the actual devices, but other ways around how to get all this. So how has the ADA and some of the other societies addressed the management of complications in their guidelines? And there were some nice series of articles last year that were published in Diabetes Care. This one looked at a very holistic approach, and it looked at identifying priority conditions and populations. If you could identify them, then maybe you could target who you're going after to try and improve the situation in care, identify targets for action, and then after you put some of these interventions in place, evaluating the impact and the equity across the population. So I do feel like there's progress being made, but we still have all these guidelines that exist, and they're trying. If you look at the top of this one's the pharmacological approach, it has added social determinants of health, that we should be looking at that. It gives you then the medical recommendations that should be delivered depending on where you fall in your conditions with diabetes. And at the bottom, it even says, afterwards, try and identify and address the social determinants or drivers of health that impact getting to these treatment goals. But they don't really give you any specifics. This is not standardized within our health system, within our EHRs on how to do this. And this is a paper from Ben Aceves, who and some of his colleagues that looked at this just a couple years ago. And they looked at the gaps in the guidelines and what's going on. And what they found is that the majority of guidelines, 77%, did not recommend anything specific for social care activities. 23% did refer to one or more social care activity, but they most commonly recommended adjustments to medical treatment based on the social risk. So we're missing a few things still here. You'll be hearing from Matthew a little bit later on some more specific recommendations on how to do this. Some of the recommended adjustments included decreasing medication costs to accommodate financial strain, changing literacy levels or language of handouts, and we have a little bit of experience with our group there that I'll show you, and providing virtual visits to accommodate transport insecurity. So these are all good recommendations, but not necessarily the specifics that are embedded within the guidelines so that we're all thinking about this all the time. One of their recommendations in the article was to think about this with using the 5 A's. I have to admit, not something that I was necessarily aware of. So again, if I'm not aware of it and I'm doing this all the time, it makes me think that we need to make others much more aware of this. And it looks at awareness, assistance, adjustment, alignment, and advocacy, and you can see what each of those means. Within the EHR, do we have screening mechanisms for social needs? Do we have recommendations to link to social services? Now, within a health system, and I hear this from our executives all the time, how much can we do? Our job is to really take care of the person when they land in the hospital, when they land in our clinic. But at the least, we could link people to experts that could deliver assistance that is needed. Should we be modifying our care plans, coordinating with community benefit organizations? And as Congresswoman Kim Schreier told us yesterday, should we be doing advocacy and meeting with our congressmen and women locally to try and promote systemic reform? I have done that and ended up after a 15-minute conversation with our local congresswoman going to the California Senate to try and promote getting diabetes education put into Medicaid to get paid for, because in California, for many years, it was not paid for. So you can make a difference when you are part of that promotion and advocacy. So let's turn back to that temple of diabetes recommendations to reduce complications. And as I looked at this, I thought, this is a great start, but maybe we need to add a few things to this temple to make it more appropriate to try and address those non-medical causes of complications. Maybe we need to add a few pillars. And up there at the top, where there was that little fellow with his sign of victory with his arms, maybe we should add a reminder. We should be screening for things other than just what we can do with our medical treatment. Look at social determinants of health. Maybe to the added pillars, we should think about adding something like provider training. Maybe train our providers on a regular basis around bias and what we should be thinking about. Are we really delivering our care equally to all? Auto EHR prompts. I've learned over the years from one of our nurses that if you put this in the EHR and you make it impossible for someone to do the wrong thing by having the right order sets and guidelines in place, it's very hard to stray. So maybe we should be having some auto EHR prompts on when someone comes in with this condition, this would be the best way to offer them some treatment. And then basic health coverage for all. Underneath at the bottom, the whole base of this temple is lifestyle modification and diabetes education. But the reality is, if you don't adapt this, it's going to be very hard for some populations to really get their benefit. So just finishing up to share what we've done in San Diego many years ago, starting back in 1997 with partners with San Diego State University, and Dr. Linda Gallo has been a great partner with me on this along the way. We put this program in place that trains peer educators when peer educators were never around, They are much more common now. In a very systematic way, we translated all the materials currently available in English, Spanish, Tagalog, Vietnamese, and Arabic, and we demonstrated that you could improve A1C values across populations. We trained peer educators in not only San Diego, but many places across the country to do this. We said this isn't enough because a lot of times you can't get to places live. And we converted the entire curriculum into a text messaging program and then tested it once again. It currently does exist in all those languages I just showed you earlier. And we did again show that you could get better A1Cs, not with a fancy smartphone, but actually just a regular text messaging phone. Last, just thinking about technology and how can this help us overcome some of these barriers. Many years ago, we had a digital camera that was placed on a bus that one of our IS techs was trained to take photos of, and he went all over the county taking photos of people that were at risk. We could think about doing something like this. Digital retinal cameras are relatively inexpensive. The FDA, it's one of the first approved AI forms of intervention, and I just saw that now with digital screenings, you can begin to identify diabetes complications. Maybe if we had these available rural and urban areas, we might be able to make a difference. So just finishing up, I thought I'd finish up with some potential solutions. Everyone has a mobile phone and some connection capability. What can we do with this? Maybe remote visits for access. Transportation is no longer a barrier. You can answer questions, receive recommendations, and communicate. Sensors are amazing. They are expensive, but maybe we could use them intermittently as needed, and that could be with blood pressure as well. Education can be delivered with a mobile phone, texting and videos, digital retinal cameras with AI interpretation at centers outside of clinics to try and reach our community. I'd like to learn more about food pharmacies and how we can connect to those, expanding access to specialties within community health centers, and then tapping into many of our amazing champions across the country that have already looked at this considerably. Shivani Agarwal and Ann Peters are just a few, but there are many others to try and really build this temple in a different way in how we deliver complication guidelines. Okay, I thought I would just finish there on a positive note that we have a lot of solutions, but I do have one last concern. This was from a study that was done back in 2015 when we did open access for everybody. And what it showed was that a whole lot of people that had never gone to community health centers or other places for their medical care all of a sudden showed up, and we found a lot more diabetes. But the hope was that if you find more earlier, you could prevent the complications. And I'm a little concerned that that might be reversing now. So I'm going to leave you with that note. I want to thank just the partners with me on not only many years, Dr. Gallo, on this, but some of our newer partners, Benasevis, Dr. Emily Rose San Diego, and Jessica McCurley. I am looking forward to what we have for the next 10 years. Thanks so much.
Thank you so much, Dr. Samikas. That was a really wonderfully thoughtful and thorough examination of these issues. Our next speaker is going to be Dr. Daryl Hudson. Daryl, would you please come up? We're going to talk with us this morning about reactions to race and racism, differential treatment that people experience based on race.
Get the, all right. Good morning, everyone. Thanks for being here bright and early on the far side of campus this morning to be with us. So that'll be the first thing I'll do is to thank you for your time and consideration today. I always start with the end at the beginning because I think an occupational hazard as a professor is that I often talk too long. But Dr. Anderson has let me know that she will keep me on track and she will hook me off of the stage if I start to go and veer too far off. So I think this is a nice way to tie both presentations together, some kind of like the meat of the sandwich, if you will, for today's symposium. As you all probably well know, around 38 1.4 million people have diabetes in the United States, so almost 12% of the population. And of those, there's people who have diabetes that have been diagnosed and those who have not been diagnosed, along with a bunch of people, almost 100 million people who have prediabetes. And we know there's documented inequities in the prevalence of diabetes across race and ethnicity. You can see these numbers here provided by the CDC, where you see there's different ranges for race and ethnic groups in the United States. And we know that social determinants are a major or key driver of prevalence and inequities in the United States. We know that there's differences across income, as higher income is associated with lower prevalence of depression, or diabetes, I should say. We know that there's key differences across education, such that people with greater levels of education have lower prevalence of diabetes. So for much of my career, and I would say for many people in this room, we're always thinking about cases and causes. I don't know if anyone's read this paper before by Jeffrey Rose. I would say if you haven't read it, it's essential reading. I make sure that every class that I teach, people see this paper by Jeffrey Rose. And so one of the core arguments there is you're thinking about cases, individual cases, versus population causes. So what is the difference? Why do some individuals get sick? Indeed, I will venture to guess that many of you in this room are here in life, in your career, because you want to know, why do some individuals get sick? It's a simple question. And like Athena mentioned, there's a lot of things in the pie chart to figure out what are the determinants. So a lot of it is around diet, especially attached to diabetes, eating fresh fruits and vegetables. But then there's a different question. Rose articulates this very well in that paper, Sick Individuals and Sick Populations. Why do some populations get sick? Which is a slightly different question. So again, I'd highly recommend delving into that paper to learn a little bit more. But in my estimation, my humble estimation, a lot of it has to do with context. So this is a picture of a neighborhood where I'm from, in Detroit, where you used to have a city block that would have houses that would hold, 40 or so homes on that block. And now there might be 3 houses that people actually live there. So you can imagine the strain on city services in terms of schooling, trash pickup, so on and so forth. But you can also imagine what health opportunities and resources are absent in those spaces. Or you can go up the road in Flint, Michigan. So I did work in Flint long before the Flint water crisis. So Flint's been struggling for a long, long time. And again, you can imagine what are the health promoting resources in those environments. So of course, there's a preponderance of fast food restaurants and advertising in those spaces juxtaposed against places that have access to fresh fruits and vegetables and other building blocks of a healthy lifestyle. So another resource that I would recommend is Segregation by Design, which is the 15-minute video that is narrated by Richard Rothstein, who wrote a book called The Color of Law. And this is a book that talks about how the United States became so segregated. And here's the screenshot of the book there. Another book is called When Affirmative Action Was White by Ira Katznelson. And some of you may know, you may remember back in high school, you probably got exposed to information about the New Deal. And people sort of miss how transformative the New Deal was for the United States. It created the middle class as we know it in America. It created still our primary older age insurance, the Social Security Act. Also, the establishment of the Homeowners Loan Corporation, or HOLC, which is where we get redlining from. And I know this will come up in Matt's talk, so just to give a little primer there, you can see one of these old HOLC maps and see what's best all the way down to hazardous, and that's where you get the redlining. So neighborhoods that were outlined in red were considered hazardous. There wouldn't be invested there historically, and then contemporarily, you can see still today where a lot of the neighborhoods of concern might be. So this on your right is a picture of Chicago, where we're at right now. I experienced this just yesterday. I had to go to a funeral with my wife here in Chicago. It just happened to be that way. And you can see this as we move from this area of town and down on the Magnificent Mile going west to where we were going to the funeral. You can see right before your eyes how things switch. And so you don't need all these data to tell you exactly what's going on in those communities and what the stressors are. Even when you go to a cemetery, we're still segregated. There's still segregation where our bodies are going into the ground in terms of where people are buried, in terms of Black people here, Latino folks here, white folks there, different religion groups, et cetera. So I think that redlining has had a profound effect on not just diabetes, but all the different outcomes that we know and care about. So a bigger plug for social context. How does social context shape social norms? Physical context shape social norms? What are the opportunities, again, that we have to engage in health promotive resource or health promotive activities? And then how can context produce or perhaps reduce health inequities? So Matt will talk about this a little bit more, but understanding social and structural determinants of health. A lot of times when I interact with groups, I always ask, what do people actually care about? And to me, that's one of the most important things that physicians can remember in interacting with patients is what can we do about the things that people really, really, truly care about? So pivoting to one specific social determinant of health, we know that racism is a fundamental cause of health inequities. We know there's structural racism, which I've described with historical redlining. We also know there's personally mediated racism or discrimination. So the objective of this particular study was to examine the relationship between experiences of differential treatment based on race and selected characteristics by diabetes status. So I'll walk through the methods here. We draw data from the behavioral risk surveillance system for years 2022 through 2023. Had just over 328,000 adults who are age 18 years and older who received the reactions to race data collection module, and they self-reported their diabetes status. So I'll talk about that in just a moment. So these data were cross-sectional. So self-reported diabetes, there's simply a question: has a doctor, nurse, or other health professional ever told you that you have diabetes? Excluded from the analysis women who indicate they only had diabetes during pregnancy. And so our main question, again, was thinking about the specific determinant of health, so exposure to racism. So investigated experiences of differential treatment based on race while at work, receiving health care or another setting, and the occurrence of physical symptoms due to treatment by race. We characterize this as any versus none. Now, I'll walk through that in just a moment. So these were the specific questions, again, thinking about the setting and the timeline in which these things happen. So within the last 12 months, when seeking healthcare, do you feel your experiences were worth the same or better compared to those of other races? And here's a figure that shows where these questions were asked throughout the United States. And the criteria here, so in yellow, there's no reactions to race module and no declaration of racism as a public health crisis. All the way out to the blue, where you can see there's a handful of states, the state I live in right now, in Michigan, where it had reactions to race module and also racism as declared as a public health problem. So you can see there's some variation there across the state, and that's not a surprise now with the amazing amount of polarization that we experience right now in the United States. And so essentially we create a composite score for reactions to race-based treatment. There's 3 categories, again, no experiences. There was one experience, so just one experience related to race-based treatment, and then 2 or more experiences. So a pretty simple way to capture exposure to racism here. So what do we find? Overall, most people didn't experience race-based treatment. That's not terribly surprising. So the majority of folks were in the note the zero experiences of race-based treatment. And the blue chart, in the blue side, you can see people with diabetes, and the green, you can see folks who don't have diabetes. But when we started to drill down into race differences, we start to see some differences do emerge, such that Black Americans, non-Hispanic Black Americans, do report, over a third of the sample indeed reported that they had experienced race-based treatment. I'll show you in just a moment where that's occurring, whether it's in healthcare, whether it's in another setting, or in healthcare, or in workplace. You also see that there's differences across other race ethnicities as well. So we want to try to figure out what's the relationship between race-based treatment by diabetes status here. So as indicated here, and this is a busy table, so I'll just put the major points there to take away from this slide here on the side. All minoritized groups had greater odds of experiencing race-based treatment relative to white Americans. Again, Black Americans were most likely to experience race-based treatment compared to white Americans. And then I wanted to look at some of our common sort of health-related factors like insurance status and chronic diseases and other chronic diseases. So we can see here that poor mental health and a history of depression were associated with greater odds of experiencing race-based treatment. And then current smokers also were significantly more likely to experience race-based treatment. As mentioned before, drilling into where this is occurring. So most of this is in workplace settings, as you might imagine. The United States, again, being so segregated, for many, especially for many Black Americans, the only place that they might interact with people who are different than them will probably be in a workplace or educational setting. You also see healthcare there, not as much in healthcare. You see it in other settings. And then you also see it in physical symptoms. So physical symptoms is associated with physical symptoms that people feel when they experience differential treatment. So sweaty palms, heart palpitations, things like that. So essentially, how does stress get under the skin? And then we broke it down even more by race and ethnicity by the setting. And again, non-Hispanic Black Americans had the highest rate of race-based treatment among people with diabetes and people without diabetes. So to summarize what we have here, overall experience of race-based treatment in this sample, again, this is a sample of just over 300,000 people. About 14% of people with diabetes had experienced some type of race-based treatment, and then about 12% of people without diabetes had some experience of race-based treatment. When we drill into racial ethnic differences, again, most minoritized groups had greater odds of experiencing race-based treatment compared to white Americans. And Black Americans experienced the greatest odds relative to white Americans. Other social factors were mixed, so I would say we had a lot of slides here and a lot of tables and figures that we could have shared with you. But for the purposes of time today, we decided to just mostly focus on the discrimination aspect. But if people are very interested, and when we get into the Q&A, we can certainly talk about some of the other factors that were there. Again, workplace setting was the most likely for people to experience exposure to race-based treatment. So there are a number of limitations, and then those kind of tied to the next steps with this work. And I would say this is really just the tip of the iceberg here. So we weren't able to calculate estimates for Native Hawaiians and Pacific Islanders. So even though there was a very large sample, we only had 394 Native Hawaiians and Pacific Islanders in that particular sample. Another major limitation I would say is intersectionality. So we all have multiple social identities that we're presenting to the world simultaneously. Your race, ethnicity, your religious background, sexual orientation, gender status, etc. So it's very difficult to parse out which one of those things might be related to differential treatment. So when we ask respondents to respond, what do you think about differential treatment and why are you being treated differently? It's oftentimes difficult because people, again, have multiple identities that are working simultaneously. So therefore, there's probably an underestimation of race-based treatment here. And if you know the discrimination literature, you know there's others, well-known measures, everyday discrimination scale, the major events discrimination scale that could be used, but those are longer surveys. So the advantage of using this is that it's only 4 items. And there's some nuances here that I'd like to briefly go into. One of the things that I study in one of my sub areas is cost of upward social mobility. So again, for many people of color, because of the level of segregation that exists in the United States, in order to achieve higher levels of education, to get a better paying job, et cetera, it forces you to move out of your comfort zone into different spaces where, again, you might be exposed to greater levels of discrimination in those settings. So even if that's what we sort of tell people to do, get more education, you have to think about what are people going through in that process and how does that relate to chronic disease. And then another thing to think about related to that would be interaction. So how are all these factors interacting with one another? Racism or exposure to discrimination, time, say, socioeconomic status, and how does that relate to diabetes status? And as I mentioned at the very beginning, there's a tension between individual cases and population causes. So of course we can know lots and lots about individual cases, but how does that translate up to broader population factors? And to wrap things up, I was questioning where are we going as a broader field? So whether it's public health, medicine, subfields such as the ADA here. I don't know if people remember this controversy from JAMA a few years ago, and this was just 5 years ago, where one of the editors for JAMA said, there is no physician is racist, so how can there be structural racism in America? An explanation of the idea by doctors for doctors and a user-friendly podcast from the great 2 white guys. And so I think that, again, underscoring that people are experiencing these slights on a daily basis. They're accumulating. So I think that's another aspect that can be fodder for future research that people are looking into is how's the accumulation of slights and stressors, how does that affect not just diabetes, but other health conditions as well? And also, how do we talk about, so as Athena mentioned, whether it's training and how we're talking to medical students about this, how we're talking to people who are training medical students and residents, et cetera. So to conclude, again, there's, especially for Black Americans and some of our other racial ethnic groups here, there's a high exposure to race-based treatment within the sample. Overall low, but certainly when you get into the nuances of race and ethnicity, you see there's differences there. Again, nuances that are worth underscoring again, intersectionality, also generational differences. I find that is also very difficult when we think about older adults versus younger adults. There's differences in how they perceive the world around them. There's other levels of racism. So this figure here is drawn from Kamara Phyllis Jones' Levels of Racism paper, which is 3 pages, by the way, in the American Journal of Public Health, which I'd recommend is another paper to take a look at, differentiating between discrimination and broader structural and institutionalized racism. And the other thing I will talk about is vigilance and performance. So how are people staying hypervigilant in anticipation of poor treatment, and how that again might affect different health outcomes. Implications for care in my last 10 seconds. Again, thinking about multiple levels of intervention, as Athena mentioned, thinking about neighborhood resources and healthcare access, building trust and rapport. And obviously if people are feeling they're being treated differently, then trust and rapport could certainly suffer. As I mentioned before, chronic stress and weathering might be a piece of that. And then as Athena mentioned, peer-led interventions might also be a way to combat some of these issues. So that's my talk. Thank you all for your attention. I appreciate the time.
Thank you so much, Dr. Hudson. Wonderful talk. And last but not least, we have Dr. Matt O'Brien from Northwestern Feinberg School of Medicine, who will be talking about increasing our stride toward overcoming health inequities in diabetes care.
All right, thank you, Stephanie. Thank you, everybody, for coming here. Happy to have the opportunity to talk about some things that I've been looking into and working on related to how can we actually address these factors that Athena and Daryl have been talking about. So just an overview here, I'm going to talk a little more and delve into a little more depth about the social determinants of health and health-related social needs, because I'm going to argue here today that if we really want to move the needle on disparities, and we've been talking about this, I got into my research career in 2007. We've been talking about inequities, for much longer than that, and we're really not moving the needle. And so I'm going to argue here today that if we are going to move the needle, we really need to go upstream. And so I'm going to talk about some of the background literature about how these upstream social factors are related to diabetes, and then really focus most of my talk on what can we do about it, concrete actions that healthcare providers, health systems can take to address them, and then talk about what the future may hold in this area. So I think everyone knows this. I won't spend much time on it. This is a definition of the social determinants of health in Healthy People 2030. These are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. And so we've heard about what these are. We're talking about economic or financial stability, education, housing, neighborhood conditions, food access, and the social context. And like we saw on Athena's slide earlier, there are many, many studies that have tried to estimate what is the impact of these social factors on health. And we see that they account for, somewhere around half or maybe upwards of half of our health outcomes are determined by these factors that we routinely don't address in healthcare. And here is an unfortunate example of the social determinants of health at work. This is another map of our city here of Chicago, and this is looking at the subway map, or the L map. This was done by a colleague and great health equity advocate at Rush University. But it's looking at life expectancy in the city of Chicago according to our subway map. And you can see where, Northwestern, my health system, is located is kind of around this area called the Loop, or maybe a little bit north of that, where the life expectancy is 85 years. And then you get on our L and you go around the loop and you hop on the blue line and you travel 4 or 5 stops west, and we get to West Garfield Park, where the life expectancy is 16 years lower. That is just an unbelievable impact of these social factors on probably the most serious outcome we could possibly imagine, which is life expectancy. And we have throughout this city, including in underserved communities, we have excellent world-class medical centers. So this is not just related to healthcare, of course. This is related to the conditions in these communities. And I want to draw a distinction here between social determinants of health and health-related social needs. So health-related social needs are really where the rubber meets the road for individuals. So while we've been talking about social determinants of health like poverty or the built environment, like the picture Daryl showed from Detroit, the health-related social needs are how those upstream factors impact an individual directly. So food insecurity or housing instability. Social determinants are operating on a large-scale population and system scale, whereas health-related social needs are operating on the level of the individual or the family. The focus in social determinants is kind of the most upstream that you could imagine, whereas the focus with health-related social needs is, again, these are the immediate personal needs people have. So we're focusing on individuals and families. The actors who can make a difference here, in terms of social determinants, I would argue a lot of that work, really rests within the purview of policymakers. Whereas for health-related social needs, that really falls within the purview of healthcare providers, healthcare organizations, and also community-based social service organizations. And the interventions are different. Again, I mentioned with social determinants, we're talking about largely policy-level interventions, whereas for health-related social needs, we're talking about interventions to link people with social care or to integrate social care within the healthcare context. And unfortunately, again, I think everybody here already knows this, but social determinants of health and health-related social needs unfortunately impact racial and ethnic minority populations disproportionately, and they're the primary contributor to health disparities. So again, if we're really going to move the needle on disparities, I really think we have to figure out within the healthcare context, how can we make an impact? So just a little background on health-related social needs and diabetes. We know that social needs are associated with a higher risk of diabetes, of developing diabetes, and that occurs kind of in a dose-response relationship. The more social needs one has, the higher their risk of developing diabetes. And we know that this risk that social needs confer on diabetes is independent of family history of diabetes, it's independent of body mass index and other traditional risk factors for diabetes. And social needs really impact an individual's ability to manage diabetes. You know, as we all know, diabetes is a disease that really requires intensive behavioral management. And unfortunately, health-related social needs really stands in the way of important things like taking our medications, glucose self-monitoring, healthy eating, and physical activity. And then unfortunately, health-related social needs have a very strong association with poor diabetes outcomes, uncontrolled diabetes, diabetes-related complications, and unfortunately, diabetes-related mortality. So now that I've painted a grim picture here of the impact of social factors on diabetes, let's talk about what we can actually do about it. And I'm going to come back to this report that Athena referred to at the end of her talk from the National Academy of Medicine, and this came out in 2019. And I really would encourage everyone who isn't familiar with to read this report and look at it. It's called Integrating Social Care into the Delivery of Healthcare. And these experts talked about, again, as Athena mentioned, the 5 A's, which really describe ways that we can address social drivers of health or health-related social needs in the clinical context. So awareness, relates to screening and documentation of social needs. Adjustment refers to how we as healthcare providers can tailor individuals' diabetes care to their unique social environment or context. Assistance refers to making referrals to services where people's social needs can be addressed. Alignment, one way of thinking about that is how health systems can invest in health-related social needs and social determinants of health. And then advocacy is the role that healthcare providers can play, both advocacy with individual patients and also advocacy in the policy arena. So I'm going to talk about each of these in turn. Screening for health-related social needs is already recommended by many expert groups, including the American Diabetes Association, but you see others here, pediatrics, obstetrics and gynecology, the VA, et cetera. And there have been some requirements for documenting health-related social needs. Some went into effect last year by the Centers for Medicare and Medicaid, and the Joint Commission also, which certifies hospitals, also had requirements for documenting health-related social needs. In this current political context, unfortunately, those requirements are in flux and may likely be changing. We know that screening is happening on a large scale already, right? So about 2/3 of outpatient practices are doing some form of social needs screening in almost all hospitals. But the way that that's done is very different in different places. So we know that, the protocols are different, the workflows are different, the types of questions that are being asked are different, the numbers of social needs that are asked about are different in different healthcare settings. So not a lot of standardization. And we know that this is really hard work. It's labor intensive, it requires a lot of staff and therefore is expensive. A lot of people are thinking about how can we leverage technology, machine learning, and artificial intelligence to help us perhaps be more efficient and more effective in this space. But unfortunately, those types of tech tools are not being widely used and may not be ready for the prime time yet. There are a lot of unanswered questions. I don't want to go into depth. We can likely get into some of this in the discussion that follows, but, who is the best, member of the healthcare team to do this work? Is it a social worker? I think many of us would argue it's definitely not a clinician who has very limited time with patients, but who should be doing this work? What are the best screening tools to use? There are many of them out there. Some of them have been rigorously studied and validated. Who should be screened? Should this be done universally? Or should it be more targeted, perhaps, on those who are more likely to have social needs or those who want help addressing their social needs, if identified? And then what's the right screening interval? We know that social needs are very dynamic, right? Somebody who has unstable housing today may not tomorrow, or vice versa. And so what's the right interval for screening for social needs? And then there's also an ethical concern, and housing is a good example of it here in Chicago. This is an area where I've been doing a lot of work at Northwestern and with a consortium of healthcare providers around the city. We have a huge homelessness problem here, like we do in a lot of big cities, and there are very few housing units and resources to offer. And so, there's a potential ethical concern of screening people if we're unable to actually address the social needs that are identified. And then there's really a tension here between, ideally we would have a lot of standardization in terms of how we ask these questions, which would allow us to, collect uniform data that can be compared across sites. But there's a tension between, the standardization that we would ideally like and then the flexibility which healthcare systems require based on their unique context. So let's look at adjustment. This is, again, how we can tailor diabetes care for each individual's unique social context. Here's some examples of how we can do that. And this is something all of us as healthcare providers can do in our office every day. One, there are a lot of challenges with injectable medicines. And so, thinking about people who have housing instability or who don't have reliable utility access. We know that in shelters, for example, most shelters don't allow needles and don't have refrigeration that's required for injectable medicines. So thinking about that in the context of housing instability. A lot of times I think as at least as physicians and nurse practitioners and others, we don't really do a very good job of making dietary recommendations that are, practical, affordable, and that leverage a knowledge of the local food supply. I think we really, especially for folks who have health-related social needs, this is critically important. Same is true for physical activity, again, another cornerstone of diabetes management. But, folks who have health-related social needs often do not have, the resources to have a gym membership and may not have, safe places in their neighborhood where they can exercise outside. So thinking creatively about what are home-based exercise programs that people could follow without the need for a treadmill in their basement. And there are many, many YouTube channels where we can find these types of resources. A lot of times we recommend probably more frequent glucose monitoring than we need to do. And we know that strips can be expensive and are sometimes only covered in certain amounts per month. And so really, thinking about how much do we really need people to check their glucose is important. We can probably reduce the frequency of glucose self-monitoring. And as Athena mentioned in her presentation, telehealth really does seem to be an opportunity here. Transportation barriers are huge. That's one of the most common health-related social needs. And now in the post-COVID era and with a digital divide that's closing, we really do have an opportunity to address that in a pretty easy way. So now moving on to assistance. So this is, how do we actually meet the social need once it's been identified? I put this table together with, this, let me back up for a second. This is a huge, rapidly expanding area of research. And, it's impossible on any one slide or in any one presentation to really delve into it in too much depth because there's so many studies and so many happening, just in the last year or two. But I put together this table with what I think is kind of a representative sample of some nice studies that have been done and also that highlights some of the different research designs and some of the challenges with this kind of work. So some so-called assistance programs here have targeted any social need. So they've had an intervention that starts with screening and then progresses to, trying to meet that need by some type of navigation or care coordination service. Other programs have focused on financial hardship specifically and financial incentives for people to meet diabetes-related health targets. In this literature of, trying to address health-related social needs, most studies, I would say, have addressed food insecurity. And we have examples of, small randomized trials and observational designs, observational studies that have looked at that. And a very interesting study that we don't have time to go into here on housing instability. There's a very rigorous randomized trial that was done by the Department of Housing and Urban Development, where they randomized people to get housing vouchers that would allow them the opportunity to move to low poverty areas, and found impressive reductions in the prevalence of class 3 obesity and diabetes. So just to highlight what we've learned from this large body of work and what we're continuing to learn, the evidence base still needs strengthening. Many of these studies have small samples. As you saw on the previous slide, they're variable study designs, often short-term follow-up periods. And many of these studies, surprisingly, maybe not many, but a good number of these studies that have focused on patients with diabetes do not examine diabetes outcomes. So that's really obviously critically important here. We've learned from this type of work that the programs that are available to address health-related social needs are hyper-local, right? And they're dynamic, like the community-based organizations themselves change, and the programs that are offered by those community-based organizations change over time. And they vary significantly from community to community, even within the city of Chicago, for example. An interesting thing that I've found in some of my own work on this topic is there's a substantial proportion of patients with health-related social needs who don't want any help addressing them. And this was really very counterintuitive to me in some of the housing work that I've been doing here at Northwestern. But I've looked in the literature and people have actually studied this, and it turns out that in some cases up to 3/4 of people who have health-related social needs do not want our help in addressing them. There are a number of reasons for that we can talk about. Another important lesson we've learned from this emerging or growing literature is that navigation interventions seem to be the most effective. And these are ones where, individuals, it could be community health workers, it could be other health advocates or health coaches, are helping people navigate to the services they need. Very interestingly, even with some of these studies, even when health-related social needs have not been met, so that individual was not able to get housing or they were not able to get the food resource they needed, these navigation interventions have even in those settings shown improvements in glycemic control. So that raises question about, what are the mechanisms through which these programs are working? Is it just meeting the health-related social need, or is there social support that's being offered, or other ways that these programs may be improving glycemic control? So now I want to talk about what health systems can do, in this area that the National Academy of Medicine report calls alignment. So there are generally 3 models of how health systems have invested in health-related social needs. The first is developing their own programs. This could be a nutrition program. It could be, a program locally to address housing in some way. More common than that is related to that is funding staff, internal staff, who are kind of bridges, between the healthcare context and the community setting where the social needs are addressed. And then another model is health systems have paid social service organizations and community-based organizations to meet those health-related social needs for their patients. Sometimes this is done in like a fee-for-service type of way for each individual patient, and other times, and more commonly, this is done in the form of grants that are offered from the health system to community-based organizations. And a big factor here in recent years that guides these health system investments is called the Community Health Needs Assessment. And this was required by the Affordable Care Act. And every nonprofit health system every 3 years has to go through a fairly rigorous process of defining what their community health needs are. So among the community they serve, what are the most important needs? And many of these focus on social needs. And they have to define in this report, how they're spending towards those needs and how they're trying to address them through community benefit. So there are substantial investments happening on the part of health systems in these upstream social factors. There was one study that estimated that direct investments, oh boy, gotta move fast here, okay. Direct investments in health-related social needs or social determinants totaled $2.5 billion between 2017 and 2019. There's another, I think, much more powerful way that we can address social determinants of health in health systems, and that's something called the anchor strategy. I don't know if anyone's familiar with this, but as huge employers like Northwestern Medicine, for example, I think we employ about 40,000 people. And as an anchor institution in Chicago, we focus on making sure our employment practices are focused throughout our entire service area and really specifically focused on some of the underserved or disadvantaged communities that we serve. Similarly, procurement, when you think about a huge health system, right, and we have a lot of meetings where food is provided, instead of going to some big national food vendor, can we source that food locally, from a minority-owned business, for example? Same thing with, you think about all the healthcare providers who wear white coats, and those white coats need to be laundered. So healthcare systems, instead of going to some big national vendor, they can put that business and invest that money into local communities, which really can address the underlying, social determinants, not just health-related social needs, but this is going even farther upstream. And one study estimated that those investments through I think about 100 anchor institutions around the country total, over $150 billion a year. So those are substantial investments. I won't go into this in depth. This is just one example of a targeted investment on the part of a health system, in this case Geisinger in Pennsylvania, focused on diabetes and having a fresh food pharmacy program. But one point to highlight here from this is that there is, some evidence of cost savings with these programs. While they are expensive, they can reap some return on that investment over time. And finally, I want to focus on advocacy. I like this quote: "Advocacy, like politics, is often local. It takes place in our offices." And this really highlights the role that we all can play. These factors may seem like they're out of our control and intractable, and what are we going to do about them? But here's some examples of things that we can do every day with patients. There are many strategies to promote medication access. I won't go into them, but we need to familiarize ourselves with those and how they work. Something as simple as filling out paperwork, for accommodations in the work setting or in school. While that may seem like drudgery to fill out paperwork as a provider, I would argue that's a really important way that we can advocate for our patients with diabetes. This is another very important one is, I would argue we should not be turning away patients who arrive late. Transportation barriers are among the most common health-related social needs that exist. And so if we turn people away, we're depriving them an opportunity of being able to, advance their diabetes care and improve their health. There are many advocacy efforts that we can join as providers, and our voice, I think resonates at many levels. The American Diabetes Association does a lot of advocacy work, but also, as was mentioned earlier, advocating with, our local and national elected officials is another important strategy. So what does the future hold in my last minute, if I have a minute? Is, as I mentioned earlier, the research in this area does need to be strengthened. However, I would argue that we do have enough evidence to know we need to be doing this work and we need to be doing it better. A lot of the studies have not measured health equity itself. Are we promoting equity? Are we reducing disparities at the level of a health system? I think we really need to start looking in that direction. As I mentioned to or alluded to earlier, I think we need to dive deeper into how these programs are actually working. I think it's not quite as simple as saying, if we meet a social need, that's directly going to translate into improvement in their diabetes outcomes. There are probably other factors like social support that are operating and important there. Increased funding, I'll highlight that one. You know, I looked, tried to figure out how much money the NIH invests in this, and it turns out, as we saw in the earlier slides, social determinants of health and health-related social needs impact, we think, up to about 50 or 60% of health outcomes, yet is under 10% of the NIH's spending. There are a lot of infrastructure needs, you know, as it relates to, you know, health systems partnering with community-based organization. That includes staffing, it includes referral technology, data transfer, billing systems. You know, increasingly, some social services are being reimbursed by insurers, and so community-based organizations are now needing to develop billing infrastructure. How do I bill Medicaid for providing food access, for example? So a lot of infrastructure needs that are required to do this work better. And there are some, you know, existing and emerging reimbursement or funding streams for this kind of work that are important. I won't go into great depth on these. The Accountable Health Communities program from the Centers for Medicare and Medicaid was the first effort to bring healthcare systems and social service providers together. Value-based care is a way that we can invest not just in, you know, get paid to provide a service, but actually get paid to deliver value. And so if we're ultimately being incentivized or paid to get someone's A1C under 8% or 9%, then maybe we actually would focus on the upstream social factors. Medicaid has this mechanism called 1115 waivers for reimbursing for health-related social needs. And there are also ways that institutions can you know, support this work just through the return on investment. So I'll just close, finally, this is my last slide, and this is a quote from one of my heroes and mentors, whose name is Jack Geiger. He was the founder of the first community health center in the Mississippi Delta. So this is the progenitor of all the federally qualified health centers that now serve, you know, over 30 million Americans. And Jack Geiger said, "We have been able to do things under the general umbrella of health that would have been much harder to do if we'd said we were here for economic development or social change." So if you think of what they were doing in the 1960s, in the early 1960s, you know, he was really going upstream and impacting, you know, sanitation systems and transportation systems to improve the health of this rural community. I think in this current political context, I think we really need to think about the way that healthcare organizations and healthcare providers, how we can use health as a tool for social justice and social change. So thank you very much. I'll stop there. Yeah.
All right, I want to invite all of our presenters up to the stage, and we will open the floor now for questions. We happen to have the shortest stage here possible, so hopefully you can see everyone. We'll put the speakers on the far end. And welcome, we have our first question here.
Hi, Dan Rubin, Temple University of Philadelphia. Maybe this question mostly for Dr. Bry, but happy to hear from other panelists. It seems like one of the big problems is the incredible fragmentation of our healthcare system and social safety net, because no one party is really responsible for all the people in a given area. And that value-based care, you know, could be really the way to go to really make the broader change that we need. There have been pockets of examples in like Maryland, and talking about institutional ROI at Temple. They gave housing to many of the highest utilizers of hospitals and emergency rooms in the Temple health system, and they cut reutilization by significant proportion, and there was substantial return on investment just for Temple, not to mention all the other, you know, great things that flow out of that. And I'm wondering, I was going to ask, you know, it seemed like value-based change was inevitable with ACA passing and all of these pilot programs in CMS. Now that seems more in question. I was going to ask, where do you think value-based change is going, and is that actually going to happen on a broader scale? But maybe, you know, do you think we need to pivot in the next few years to be advocating more for the institutional ROI level? You know, the individuals in health systems, we can advocate for those things, and at least our own institutions can make change at the more local level, or you know, how do you see that playing out? Do you think, you know, that has promise?
No, that's a great question. Thank you. And I'll start and hand it over to others for your thoughts. You I agree. I think we had really a huge groundswell of interest in these types of models that, were more integrated and that were, trying to bring healthcare organizations together with social service organizations. The Medicare Accountable Communities model was really an extremely impressive and ambitious one that, started several years ago, and evaluations of that are ongoing. Unfortunately, I think in this administration, we're not going to see programs like that grow and thrive. And so I think, we do have to consider, like, what are the other ways to do this important work? I think the institutional ROI is huge. We've seen examples like the one you described at Temple, where we can really have a huge impact on addressing social needs. And so we're doing the right thing, but it's also impacting our bottom line in positive ways. And, while I don't have to think about that because I'm not a senior health system leader, the guy who gets paid the big bucks who, sits on the 40th floor of our building does think about things that way. And so I think trying to demonstrate what the ROI is, and, I think that feeds into our research. Like, we need to be measuring what the costs are and whether the, programs are cost effective or even cost saving. And in many cases they are. So I think that's one way that you mentioned. I think we really do need to be doing that more. It seems to me that value-based care is really taking off, and even in the private context. So a lot of private insurers, and there are health systems that have really entered this value-based care world and are doing well financially. And so I think that's a model then that's not quite as dependent on the government. Aetna is doing a lot in value-based care. I think in certain parts of the country, there's more penetration of value-based care models. In the Midwest, I think we have a lot less of that than in the Northeast, where you are. But it's growing, and it's growing rapidly. And I think the fact that private companies are doing this work, gives us hope that, even in a political administration like this one, we can make progress. And there are also examples where insurers have done what you said Temple did. I remember a project that United Healthcare, which is the biggest insurer in the country, has done to, purchase like warehouse buildings and gut rehab them and house their beneficiaries in, housing units that they created. And they also found a big ROI. When you think about someone who, we do a lot of work in our ER and ERs around Chicago around housing instability. And some people we see are in the ER more than once a day. I mean, we had one person who had, I think it was 450 ER visits last year. When you think about the cost of 450 ER visits in a year compared to the cost of rent for that individual, health systems can save a heck of a lot of money by spending $1,000 a month to put somebody, or the insurance company, whomever the payer is, could save a lot of money by spending $1,000 on a month on a housing unit versus more than $1,000 for each of those ER visits. So I think we're in a period politically where it's really, I think, demoralizing for many of us who care about these issues. But I think there are a lot of things we can do, even in this political context, to move the needle.
Can I add just from a practical perspective in our health system, some examples that I've seen, diabetes specific as well. Diabetes in pregnancy is something that, we're a not-for-profit community health system, but we take a lot of private insurance and not so much Medicaid in our clinical environment. In our hospitals, we take everything. And one of the best ways that we could connect across this fractured health system that you talked about is if we can connect to our federally qualified health centers that have amazing resources many times for the social components. But there has been barriers. How do we connect people? They leave from the ER, they get discharged from our hospitals, and then how do we connect them? And one big area that has changed is we're beginning to have one EHR across the entire county. And where we couldn't communicate to each other, now we can begin to communicate. So I know there was a lot of effort to try and get this communication between EHRs years ago. Didn't really work very well for us. But almost every health system now in San Diego has converted to Epic. It's kind of crazy, but you can begin to see everyone's records across the entire county, and very helpful. So from a practical perspective, I think that might be able to help us.
And isn't there a community information exchange? Do you know about that in San Diego? Have you interacted with that?
It didn't progress very well.
Did it not? Okay. Because we're developing one of those here in Cook County, which, if it is successful, will be the largest one in the country. And a community information exchange is taking what you described, Athena, to the next level. It's not just having all of the healthcare data in one place and interoperable, but it's bringing in data from social service organizations. And so we can see in real time for that person who's in the ER and says they're unhoused, oh, look, there's a housing unit at Thresholds, which is a Chicago-based organization. Let's call Thresholds and get that individual directly plugged in with care. I think that's a huge piece of infrastructure that carries a lot of promise, but I think there have been many challenges in implementing them or developing them.
Yeah. Thank you all. Thank you. So there's another theme that I think came up in all three presentations. And so maybe I'll offer, Dr. Hudson, you can start on this one. And that is the workforce and potential looming changes in the workforce given the landscape that we're all operating in now with threats to biomedical research funding and federal sponsorship of a lot of healthcare issues. So when Dr. Smikas was giving her presentation, she mentioned the prompts for AI and how the retrieval of information shifted as the prompts shifted and became a bit more intelligent around the issue at hand. Similarly, Dr. Hudson, when you talked about the reactions to race module and the importance of how we talk to students, how we teach around these issues, whether they're in public health or clinical settings. And then Dr. O'Brien, you mentioned which team member addresses the health-related social needs, right? And so I am just curious about your perspectives on how do we continue to shape a workforce to do the kinds of things that you're presenting to us on today, and the additional work that needs to be done if we indeed want to be evidence-based in how we put forward recommendations and programs.
It's a really easy question. Thank you. I'm being sarcastic. That's a really good question. So I guess from my neck of the woods, thinking about development of workforce, especially in these socio-political times, I can't sugarcoat the reality that we're in. So what I've tried to do in terms of training, back when I was at Washington University in St. Louis, we completely reformed the way we taught physicians. We remade our curriculum to focus much more on social and structural determinants of health. We included health equity modules throughout, not just one specific class. We tried to weave it throughout the entire 4-year experience and beyond. So I think that's the type of integration across the entire spectrum. Again, I think the students are a little bit different than folks who are on the other end of the classroom. So we know we can't touch everyone in the training experience. And so I think that's a bigger challenge is some of those people are retiring, but how do you get the folks who hold a lot of cards and have a lot of power, who can just evaporate all the progress that you've made in a class over a course of a year and just say something offhand and say, oh, that stuff doesn't matter. Like, we should be focusing on X, Y, and Z. So I think that's one way. I think the other thing I'll say broader is how do we get other people to understand that we're all in this together? The pandemic should have taught us that, but I don't think it did. I'm still trying to investigate why that didn't occur, but I think that the more we can get people, like Matt mentioned, it's in our own best interest. So being selfish about it. When I think about equity, how can we frame equity so that people can see their own benefit? And what does it mean for them if other people are healthy, whether it's costs, whether it's, having more amenities in the community, et cetera. So that's a broader thing that I try to do.
I might ask too, if you have good tools, when we went out to do an LMS module, learning management system, which would affect not only our clinicians and providers, but actually your front desk people that are checking in, that are answering the phones, that are communicating with our patients every day. I did not find a lot of tools that I could put in to use this. So if there are good tools, I would love our guidelines to embed very specific. Here's something that's been looked at, used successfully, consider it maybe as part of your training for the entire workforce, as you mentioned, not just our clinicians.
And I'll just add quickly, I think we need to invest much more heavily in a different workforce. We spend so much money in our healthcare system on physicians and healthcare providers, which I'm one. I think they're important, I hope. But we really underinvest in the types of staff who can help us in dealing with social needs. And we know other countries, I saw an analysis of OECD countries, so other, developed economies around the world and in Europe. For every dollar they invest in healthcare, they invest $2 in social services. And in our country, that's flipped. For every dollar we invest in healthcare, we invest 55 cents in social services. So I think in right-sizing the workforce, we need to have fewer clinical staff and more social staff.
Thank you for that. How the time flies. We'll take our last question from Daniel.
Yes, hello. Amazing talks. Thank y'all so much. My name is Daniel Okordudu. I'm at UT Southwestern in Parkland Hospital in Dallas. I'm curious your take on social media misinformation and maybe its impact on different demographics. I recently returned back to academia, and that's one of the themes that I've noticed. It seems as though different groups have different influencers that they're following, and there's a lot of misinformation that's out there. In particular, the story that I have of a patient of mine, African-American male, 60-something years old, type 2 diabetes, very uncontrolled. We got his A1C down, all the way down to like 7.2 or so. He's on insulin pump on the AID system and doing well. I've seen him for the past 5 years. He went through all these different interventions, education, all of this. And, it was really deflating because our last visit, he tells me, well, next time I see you, I'm going to be off the insulin. And he has type 1 diabetes. And so I asked him, where did you get this information from? And he mentioned the influencer he got it from, a guy named Dr. Sebi, who's pretty popular herbalist and African-American male amongst my African-American males. So anyway, I'm just kind of curious, if there are ways to tackle this, or if you think how much this influences, demographically and things like that.
I might just say you really hit an interesting issue, because it can go both ways, right? You can have social media that can really impart interesting and good information. Glucose Goddess and some other folks that are out there give great dietary, some of the things that you mentioned, Daryl, advice. But then others that get on the fringe and the edge like this, and then how do you overcome that? And sometimes, I mentioned our peer educator programs. That's sort of peer-to-peer talking to each other. We train our peers to communicate the correct information and to overcome myths. And maybe that's a way to try and speak. Because sometimes I can tell you, when I'm talking to my patients, they're not necessarily listening to me when they've found this person on social media. So another way to try and overcome what they've heard through their own peers and who they're listening to. Just a thought.
Another easy question. Thanks for that. I think about this a lot. I think speed of information, access to information in these contemporary times are absolutely immense and can't be understated. So I think that in terms of how to deal with it at a broader level, I think we're still working on solutions to try to figure out how to grab people's attention. I think that's one thing that social media has really done in an extremely efficient manner is grabs people's attentions, holds it. So kudos to you all for sticking around for the entire session. Maybe to us too for holding your attention. But I think nowadays how people digest information is in 30-second sound bites on a video. And beyond that, it's really difficult to hold people's attention. When I lecture to people who've invested an incredible amount of time in themselves and money into their own education, you've got about 17 minutes before people are like, I'm checked out. So I think in one-on-one patient interactions, however, asking questions, I think especially among the Black community, there's real harms that have been done that could really explain why someone might not trust the biomedical, medical and research system. And so acknowledging that harms have occurred, recognizing that, and not sweeping it in the rug and saying, oh, that's a dumb idea, but trying to understand, like, well, why would you think that? And trying to, gently redirect them. So it's not an easy answer. I know it's very clumsy, but that's the best of it. Advice that I have is just meeting people where they're at and trying to provide additional information.
And maybe we should bring that into the history we take of patients. I mean, if you're hearing that, I've heard this one or two times myself too, and it's like, well, wow, maybe we really need to understand what are the sources of information that our patients are having, and if the information they're getting is misinformation or disinformation, trying to dispel that. But again, you probably have 15 minutes with a patient, right? And so does that really give you enough time to get into this and try to explain the information in the way that the patient can understand it? And but ideally we have trusting relationships with our patients, so we hopefully could influence them if they're being under the undue influence of someone who doesn't really know what they're talking about and is giving them bad information. Hopefully we can counteract that. But boy, I agree with everything everyone said. That's a huge challenge in our contemporary times.
Can I just one last thing you might think about is try calling some of your local reporters. We had some really odd things going on with microdosing intravenously of insulin by providers across the country, theoretically to improve diabetes. And one of our local reporters took this on, and she ended up taking it across the entire country. They ended up shutting down many of these places that were doing this. So traditional media sometimes can counteract some of the social media as well.
So thank you so much to our three excellent speakers. Thank you all for hanging in with us. Enjoy the rest of the sessions.